Committee on Health and Human Services is called to order. Clerk, please take the roll.
Chair Morse.
Here.
Vice Chair Martis. Here. Representative Hood. Present. Representative Brabeck. Here. Representative O'Neill. Representative Puri. Representative Farhat. Representative Price. Representative Skaggs. Here. Representative Snyder.
Here.
Vice Chair Green. Present. Representative Bolin. Here. Representative Meerman. Representative Kuhn.
Here.
Representative Steele. Here. Madam Chair, you have a quorum.
Thank you, Clerk. First, I wanted to note for those that are joining us on Zoom, unfortunately, our video is not working this morning, the video feed to you, but I've been advised that you will be able to hear what we're saying, and we will be able to hear and see you as well. Next, we'll ask for a motion to approve the minutes of April 10th, April 25th, and October 25th. Chair Hood moves to approve said minutes. Hearing no objection, the minutes are approved. And let's see. We're going to move on with our presentation. First, we are happy to recognize, actually, I'm going to say a few words first and set the stage for this meeting. So we are all well aware that during the public health emergency, the federal government put a halt to redeterminations for Medicaid. And so as of June 2023, after a 3-year cessation in redeterminations, the state of Michigan and all the states in the union are tasked with beginning again the process of redeterminations. We thought it was important to have this meeting, for a few reasons. Number one, so we can hear how our state is doing. Number two, so they can relay, or other stakeholders in the process can relay what the needs that they see going forward will be. But we also want to acknowledge that this is a very difficult process, and in the passage of 3 years, that's highly probable that many people in these systems have moved, possibly multiple times. So we, definitely acknowledge the challenge that is presented by ensuring that people are appropriately redetermined. As the goal of the state and this body is to ensure that as many people are able to keep their insurance as possible, we just want to make sure that we as a state are doing as much as we can to ensure we're getting to people and making sure they're keeping the benefits that they are eligible for. So with that, we're going to invite the Department of Health and Human Services up today to testify. We have Erin Emerson, Senior Policy Executive, and Megan Groen, Senior Deputy Director.
Good morning. Thank you so much for having me here today. I really appreciate the opportunity to talk to you all about Medicaid redetermination. For those of you who don't know me, my name is Megan Groen. I'm the Senior Deputy Director for Behavioral and Physical Health and Aging Services at MDHHS, and in that capacity, I serve as the state's Medicaid Director. So I wanted to take just a moment to talk a little bit about the Medicaid program. This slide has some background information on the Medicaid program from a national perspective.
Sorry, Megan, can you just get a little bit closer to the mic?
Yeah.
Thank you.
All right, is this better? Okay, fantastic. So this slide has some background on the Medicaid program from a national perspective. So Medicaid is the joint federal-state program for low-income individuals and families run by states under federal rules. So that's put out by the Center for Medicaid and Medicare Services, CMS. Medicare, which is often confused with Medicaid, is the federal health insurance program for adults 65 years and older, or some people under 65 with certain disabilities. So we really wanted to highlight a little bit about the program as a whole here, and you will notice some of the certain populations that this program is very important to. Taking a look at Michigan's Medicaid program, we have 1 in 5 adults in Michigan covered in Medicaid, 3 in 8 children, 3 in 5 nursing home residents, 1 in 7 Medicare beneficiaries. So these are going to be folks who are dual eligible for Medicaid and Medicare, meaning they're both low income and over 65. And 2 in 5 people with disabilities. That's over 3 million Michiganders that we are providing health care to right now. I wanted to take a moment and point out children. You will hear us talk a lot about children in this program, both because 3 in 8 children are covered by Medicaid, but also because Michigan does Medicaid eligibility on an individual level. So that is why when we're talking in a moment about returning packets and making sure that people are getting that information back to us, even if you as an adult are over that income threshold, your children may still be able to be covered because that's a higher income threshold for the program. And so we do have a lot of children in the program, and those children will be eligible even if their parents are over income. In terms of the public health emergency unwind, as a reminder, the Medicaid program is required to check an individual's eligibility once every 12 months to ensure they still meet eligibility requirements of the program. This is what was paused under the public health emergency. So Prior to the public health emergency, we did Medicaid redeterminations every year, and then that paused during the public health emergency. So some individuals are renewed what's called ex parte or passive renewal, and that's if we can verify your income because we have it from another program or you've provided that to the state, and some are a paper process where you do verify that information with us. So in terms of the public health emergency, in 2020, Congress created the continuous coverage requirement, and so that meant that Medicaid programs did not disenroll anyone over that period. In March 31st of 2023, that continuous coverage provision ended, and in April of 2023, MDHHS started that renewal process with our first cohort, which was the June cohort. And the first coverage terminations did start in July in the state of Michigan. You will hear about other states who are much farther through the process. When I'm talking to Medicaid directors across the country, some of them have actually completed this process already.
I'm sorry. You can keep going.
Okay. And so that is something where we have a lot to learn from our colleagues that are a little bit farther ahead. In Michigan, we decided to take a little bit longer to make sure that we were able to get our message out, talk to our individuals, and make sure that we were prepared to start that renewal process. I don't know how to. Okay. So I wanted to show this slide to show the significant growth of that continuous enrollment provision. In the state of Michigan, we had a 34.2% increase in people covered in Medicaid in the state. That is a lot larger than other areas. That's nearly 820,000 individuals that are now covered in Medicaid that were not previously. So we have a lot of individuals who had never undergone a redetermination process, so they have not been in Medicaid when they had to renew their paperwork and do that piece. For everyone else, it's still been 3 years since they've gone through that process, so that's a significant amount of time. I wanted to talk a little bit about Michigan's approach to unwinding. Our number one goal is keeping residents covered, and so our highest priority is to keep as many Medicaid beneficiaries enrolled, and for those who are no longer eligible, provide a smooth transition to the federal exchange or employee-sponsored care. So our goal is to make sure that people remain insured, whether it's in Medicaid or somewhere else if they're over income, but we want to make sure people remain insured so that they can be healthy and keep their families healthy. A couple ways that we achieved this goal and are working on is enhancing this ex parte renewal process. I always think that's a little wonky. What that really means is that we are looking at people's, if we have people's income because they're on food assistance, because they're on unemployment assistance, they're on all of these things that we can verify and have income information that's recent enough, we can go ahead and renew them in the Medicaid program without even sending them a packet. So instead of getting a packet of information saying verify your income, do all of these pieces, we're able to just do that on the back end and renew them in the program. There were a lot of federal flexibilities and waivers that were offered over this public health emergency time, and right now that we were able to use. We'll go into that in a minute, but that's really helped us expand that renewal process where we can do that kind of without even having that touch. We have also conducted robust outreach with mail, phone, text messages, emails, statewide media campaigns. Another piece that we've really been able to do, and I really thank others, I think that maybe even testifying here today, but certainly those that are not in the room as well, but we've been able to partner with managed care organizations to make sure that not only the state of Michigan is talking to the beneficiaries, but their individual health plan. So if they're in a managed care health plan, so one of our Medicaid health plans, one of our PIHPs on the behavioral health side, an integrated care organization for our dual eligible population, these folks are really able to make sure that they're hearing that message from their health plans as well. Some people know they're covered by Healthy Michigan. Some people know that they're in the state Medicaid program. Some people know that they're in a health plan. As long as they're getting that information and getting their paperwork in and being renewed, that's what's important to us to achieve our goal of keeping residents covered. These are some of the waivers that the state of Michigan has applied for and received through CMS. Michigan tried to take advantage of as many of the special waivers and flexibilities that CMS offered as possible. I believe we are in the top 10, kind of on the top end of that, in terms of states being able to submit and receive these waivers from the federal government. I will not go through all of them in the interest of time, but they're all important. One that I really wanted to highlight is beneficiaries who've been procedurally closed, so they did not return a paperwork from us. They did not return that packet. We have not heard from them. They have up to 90 days to return that paperwork, and they're still eligible. And we can reinstate them back into the program when they were originally closed. So there's no gap in coverage there. So if you have that full time to return that paperwork, you get a pre-populated form in the mail. It has all of your information on it. You can still use that form, send it back to us, and we can make sure that you have no gap in coverage. If you had any healthcare services between that time, whether it be if you were in a car accident, if you had an appointment with a medical provider, all of those things, you will have no gap in coverage. And that's something that we were able to do under the public health emergency with assistance from CMS that we haven't been able to do in the past. There are also some public health emergency special flexibilities. These didn't require a waiver, but they're things that are specific to the public health emergency that we were able to use. One of the biggest ones that I will highlight is delaying the procedural terminations for beneficiaries for 1 month while the state conducts targeted outreach. So what that really means is, so if we haven't heard back from you, you would have been closed because we don't have your income eligibility, you did not return that package. You have a whole extra month where we can reach out to you and your Medicaid health plan can reach out to you to make sure that you are getting the information that you know that that packet needs to be returned. This is something we've never done before, right? Because these are flexibilities specific to the public health emergency. We didn't know exactly how it would go, right? Like how many people would really take advantage. In that first month, so we did it for 1 month, around 15,000 people used this additional month, that used that flexibility in the June cohort. And so we made sure that we went and did that for all of the cohorts just to make sure that everyone was having that same opportunity. It was something we found incredibly successful. Another one that we have used is Medicaid health plans and other managed care organizations. We're able to share our monthly list of individuals who are up for renewal and those who have not responded. So that allows the plans to contact beneficiaries via phone call, email, text message. They can really assist beneficiaries with completing their renewal paperwork so they can actually walk somebody through. For some folks, it's really easy to get through this paperwork. For others, it's really challenging, right? So they can really walk people through that. Per the CMS rules, the plans are not able to sign that renewal paperwork on behalf of their beneficiaries, so the beneficiaries do have to take that final step to return it themselves. We have worked with CMS to see if we can have some flexibility to have that additional step so that the plans can submit on behalf of their beneficiary, and unfortunately that has not been something we were successful in I don't want to say just in Michigan because nobody across the country is able to do that. But we are able to go through and partner on a number of those things. I wanted to talk for a moment just about our robust communication strategy here. So this is a media campaign. There are toolkit materials, social media, web resources. Sometimes the state of Michigan is a great messenger and people want to hear from us and the Healthy Michigan Plan. And sometimes it's better coming from a community partner, and that's okay. So we have made sure that we partnered with community organizations and others to really be able to have those robust communication materials that we're happy to put together. We can co-brand, do all of those things. So we have looked at earned media. We have made sure we have translations in Spanish and Arabic. But we do have a number of different media outlets. You may hear us at the gas station when you're pumping your gas, reminding you to get your paperwork in. It's hard to get away from that one. We've heard a lot. It seems to be really effective. So something that we're really happy to have been able to have the resources to do. I also wanted to take a moment to talk about some of the other communication strategies that we have. We have a dedicated website to make sure that people understand the beneficiary changes and that our stakeholders do, because there's a lot of people that are impacted by Medicaid redetermination, a lot of folks who are Medicaid providers who want to make sure that their patients have that information and that their patients are able to stay in the program. So we've also been convening regular meetings with our partners, statewide associations, to really hear from them about what they need. We have had regular updates with all of you in the legislature. I know that you get a bi-weekly email from Charday with a lot of information because I know constituents are calling into your office. They have questions. My first job was answering a phone in a congressional office. I learned a lot from that. I worked in the legislature. I know about working on constituent cases, and I just want to make sure that that you guys have the resources you need in your office to help those constituents and make sure that we get them the help they need. Because people kind of come through a variety of different doors, and we want to make sure that they're getting that support. We've been able to partner with a number of community-based organizations to be really on the ground, working with those beneficiaries. I'll highlight a couple events we've had with the Salvation Army that have been really successful. We were able to host a week-long Medicaid renewal event in Detroit just last week with the Salvation Army's bed and bread trucks, so they feed people who are in need. You can also renew your Medicaid with them. So it's a fantastic thing we've been able to do. That was in Detroit. We also had an event in Grand Rapids, but this is just an example of one of the great events that are really being co-hosted by us and our community partners. Beneficiaries are receiving calls, texts, emails at the beginning of the month, alerting them that it's their renewal month, that it's time to get those packets in. If they do not return their packet shortly before the end of the month, they receive another call, text message, email, reminding them to return their packet. During the next month, because of this 1-month pause and procedural terminations, they receive an additional outreach reminding them to submit their packet. So that's just on behalf of what the state's doing. I know the health plans are doing additional outreach too, just to give you a little bit of a sense of the breadth of that. DHHS has completed nearly 500,000 phone calls since June and sent close to 370,000 text message reminders to beneficiaries. I wanted to talk for a moment about our local office collaboration. There's a lot of Medicaid renewals to go through in this unwinding period. So you can see here, this is the number of renewals we have. In June, we had 228,000 individuals. We tried to keep it around the same number for every month. So these are the number of renewals going out. Some of those people will be renewed passively because I know their income. We are able to do that. Some of those individuals will get a packet from us that they need to verify their information. When they get a packet, that information comes back to our local office to be processed. So ensuring our local office success, we had to hire a lot of people to do this. This is a lot more than we've done in the past. So we were able to hire 581 additional staff in fiscal year 23, 53 in fiscal year 24. We had a number of overtime hours. The projected costs for OT are almost $20 million right now. We added for the Michigan Bridges help desk, that's $4.25 million. There was some additional costs for supervisors, staff conversations, technology enhancements, training, et cetera. I just want to, so we talked a little bit about how Medicaid beneficiaries hadn't done this in 3 years. Neither had our local offices, right? And so if you're a new MDHHS staff in a local office, you had also never done this work before. So it was an incredible amount of training to really make sure that we were prepared for this. And I just, I did want to take a moment to thank the committee because that money was appropriated here. And that's why we were able to do this work and cover the unprecedented number of redeterminations. So really sincerely thank you for that, being able to do the overtime, being able to hire the additional staff. That was something that we very much needed. In terms of where we're at, and I know that that's something people are very interested in, we're a couple months into this now. I think probably last time we talked to the committee, we were talking about what this was going to look like, and we now have some of that information. So what we do is we have made sure that we have transparent pieces on our website so that people can really understand both what we're submitting to CMS and some additional information that we think is important for people to know. So that data is available on our website, everything I'm about to show you. So this is the CMS reported data. So this is static. It is submitted once a month to CMS. The numbers don't change. And so this is what every state is submitting. So when you kind of look at those national comparisons so that it's apples to apples, this is what you're looking at. You will notice that there's a large piece in here about people who haven't returned their paperwork yet. And that's because we have that 1 month pause in procedural terminations. So we have that extra month. So none of those people have been terminated when we put the CMS data in. They have an additional month to get back that paperwork. What we did to make sure that we are able to track and communicate with others and really demonstrate what happened next is we created a second dashboard. This shows the number of passive renewals, the number of renewals from packets that are returned, the number of closures for eligibility reasons, and the number of closures due to procedural terminations. The number one reason we have a procedural termination is because somebody did not return their packet. Just to touch briefly on marketplace transitions, we have a great partnership with DIFS to ensure that we just showed a number of people were disenrolled from the Medicaid program because they are now over income. They are likely eligible for a exchange plan that is very reasonable priced, sometimes less than $10 a month. And so that's something we want to make sure there's a smooth transition so people are getting all of that information, both from us and that we're able to allow our Medicaid health plans to do that beneficiary outreach as well so that they can transition those members to make sure that they stay insured. And I did want to leave you kind of with some important resources and phone numbers. Some folks are going to be able to fill out that paperwork, send it back to us. If they haven't yet, they do have some additional time. As they're calling your office, if they still have that paperwork sitting there, they can still use that paperwork for 120 days. So send that on back to us. But if people need some help walking through that and really have some questions about what that looks like, there are a number of different ways people can help. If they just want to look up when their renewal date is, they can do that on our website. If they need information about the exchange and want to think about that even before they're disenrolled, that's wonderful. You can go to DIFS. If you have problems with MyBridges and those in your MyBridges account, we have the number up here for that, as well as talking to our local office to reach a specialist who can really walk them through those pieces and make sure that they have what they need. And with that, if you have any questions, I'm happy to take them.
Well, thank you so much for that presentation. That is a lot of information to pack into just a few minutes. And I really appreciate it. And on the community outreach front, my husband works for my community dental clinic in Battle Creek, and I went to pick him up one day, and I was waiting out in the lobby, and they had a TV in the corner, and I saw your ad, and I was like, yay! So was happy to see that. We are going to take some questions now for you all. And so we'll start with that. I'm going to let the members ask questions first. So first we have Rep. Bolin.
Thank you so much, Madam Chair. Thank you so much for being here. And also, it's a lot of work, there's no doubt. And I'm a process person, so I appreciate the overview of the process. But I have some questions that are actually about the form for redetermination and what happens with them. So one on it, you ask a question about have you been exposed to Flint water or something. Can you just give me some background on that? And you ask that question and then what happens?
Yeah.
And why you ask it?
So we have additional, so we have the Medicaid program, we have some additional eligibility for some different special populations, right? And we get those through waivers with the federal government. We do have a waiver that's specific to Flint, and so there may be additional eligibility for individuals that are in Flint that have been well, no, not necessarily that are in Flint now, that have been exposed to Flint water, right? And so I think what we're trying to do there is make sure that we're capturing everybody. If you're not eligible for traditional Medicaid anymore and in that program or Healthy Michigan plan, we're trying to make sure that we capture if you have eligibility for any of our other expanded eligibility populations.
Okay, yeah, thank you. The second one has to do with, it asks about voter registration. And so can you refer to what the authority is that's been granted to the department to ask that? And what happens when somebody says yes?
That's a good one. So in terms of, we ask about their voter registration, I'm going to have to get back with you on the exact process of what that looks like.
Okay, that's
I don't
great.
know unless you do.
I don't know exactly what we're doing with this. I do know we don't transfer that information anywhere. There is some guidance that CMS is working through that might allow states to transfer that information to their Secretary of State's office. I know there's also some state legislation that's contemplating that as well. At this point, CMS has not granted states the authority to transfer that information, so it's collected and it maintains in-house at MDHHS.
Okay, so my question really has to do with what the authority is granted that, A, you collect the information and then what to do with it. But next, on the form itself, there is some wording, and this is of particular concern to me, given that during the pandemic, we had not only abuse, but a lot of fraud in the UIA system. And so my question is about under what authority and why we would have, for so many vulnerable populations, the question on the form that says, I will have to repay any benefits I should not have received, even if it is the department's error. And I have no problem if somebody has lied on their application, it proves to be false information or something, but under what authority and situation we would have on, these are very vulnerable populations potentially, that even if it is the department's error. And then just some history, how many department errors have we had that we've cut people off of benefits or asked them to repay?
Okay. In terms of the specifics on that and the specific authority, we can make sure that we get that to your office.
And then if we have any record of people that maybe we have, the department has been in error that we're actually cut off the benefit.
Sure, and I think we can follow up with additional information. The one thing I would note is in Medicaid, it's a little bit different than some of the assistance programs, and so we don't pay benefits out to a beneficiary, and so we would not ask a beneficiary to repay a Medicaid benefit if there was a department error. And so I think some of that language is applicable across all programs, right? But Medicaid functions differently than food assistance program or TANF, right, where we are actually paying a provider on behalf of for providing a service on behalf of a beneficiary. And so we would not be going to a beneficiary and say, you must pay us for that provider's visit
Okay.
for the Medicaid program.
So then I'm confused by the statement that's actually written on the form. So you're saying the person, the recipient of Medicaid would not be responsible?
Correct. So again,
Even though it says, I will if it's a department error. I mean, they're signing their name to this form and they can't.
right, so that the form is for all department programs, right? So it's applicable in some programs as well. Are you looking at the Medicaid?
I'm looking at the Medicaid redetermination form. Very specifically, the Medicaid redetermination form.
So we can come follow back up with you on that. So I will say CMS does have a lot of requirements related to our applications and language related to that. So we can follow up whether that's a state authority or a federal authority.
Okay, thank you very much.
Rep. Steele?
Thank you. I appreciate the presentation. My question is more about, like, we have 820,000 additional recipients, and right now we have about 3 million on the plan. And when you said some states are already completed their process, one, it's like, how long do we think that it will take us to complete it? And what do you project that our end result will be? Will we be back to where we started from prior to the process? And like, what other states are completed in comparative to size? Like, is it Ohio, Illinois? And are there things that they're doing that we're not, that we could speed this process up a little bit?
Yeah, so the process will be completed in May.
In May?
In May. And so that is, I mean, it is a federal requirement that we will be completed in May. CMS is working with states who maybe might have some challenges to not complete that program by May. Michigan is not one of those states. We will be completed by May. We are on track to do that. In terms of states did make different decisions on when to start. And so that start date and how quickly they went is just really dependent on their program. I will say most states have not completed. We are certainly not a minority on that. We would be in the majority of states who are completing that who have not yet completed that process, but we will be completed by May.
And then do you think, based on the numbers of 3 million, do you have an idea of where you think we might land at the end of it all?
Yeah, I mean, that's kind of why we talk about that unprecedented growth, because it's something that to compare it to where we used to be, there were so many people added to that program, but we certainly do see, we are seeing individuals disenrolled, both because they're over income and because we aren't able to verify that income eligibility. So we will know in May exactly where we shape up compared to where we were before.
So like Ohio, for instance, they probably have close to the same population-ish that we do. Do they have as many recipients, do you know, in comparison that we do in the state of Michigan overall?
Yeah.
Or are they doing better because they have less poverty per se?
You know, I don't know the Ohio numbers off the top of my head. The Ohio Medicaid director is somebody I meet with very regularly, so I'm happy to ask her for that information and who in Ohio is.
And I'm not just saying Ohio, that was just an example of like other states.
Sure.
And then just one last question on, there's just a document on our desk here that talks about other renewal forms, and it seemed to me that you said that the physician offices, the health systems, and the social service agencies have that form available for when patients go into there, but this is saying it doesn't. So I just want to, if you could clarify that, this document versus what you had said. Do health providers have that ability to pass out the form when patients come into the doctor's offices and such?
So providers are going to be doing enrollment sometimes for their patients, right, and have that information there. Is a little bit different than the redetermination process. So they have an enrollment process. I can't really speak to if any of them have a space in the redetermination process.
Okay. So no, doctors don't have that form
They're not
available.
going to have that redetermination form, but they do have an enrollment form.
Form available that they can pass out
That
to
they
their,
can pass out. So if we receive an enrollment form for an individual,
Right.
I mean, that's something where we can certainly enroll them in the Medicaid program, and we can, be working with that individual to make sure that they have.
so the physician offices have that form available, so when they come in, they can at least get started there.
That form is available to them, to
Oh.
the physician offices. I
Oh.
can't speak to every physician's.
I just was saying the outreach, if that was available. Okay, thank you.
Rep. Brabeck?
Thanks, Chair, I appreciate it. Thank you for being here and for all the information. I know you talked about capacity and capacity building in terms of this very large task and hiring 541 folks in FY23 and then 54 in FY24. I was able to speak to our local health plan person in Washtenaw County just a couple days ago. And one of the things that we're hearing on the ground there is that it is, even with all this capacity, right, that it's hard for folks to get a hold of an individual and, and that local folks are happy to be partners, as you also talked about. So I'm just wondering if there are, I don't know if that's happening in other places around the state. I just got to talk with folks in Washtenaw. And so I just am wondering if you're seeing that in other places and if there's a need to build even more capacity to meet that May deadline.
And so I think when we're talking about capacity, we're really talking about kind of those individuals in our local offices that are doing that processing. So we do have a lot of overtime happening in our local offices, right? And so that's something that we will continue, and those are resources we're putting out. In terms of some of our partners, if they're having trouble connecting with people, that's something that I would love to know more about and kind of what those specific things are. Sometimes when we're looking at, we are very cognizant of our call center wait time and things like that. Those are things that we're reporting. Sometimes we're looking at that. You can have a 2-minute wait for the state of Michigan, and you can have a specific area that's struggling, right? And so that's something that we need to know so that we can look at if we need to ramp up resources in that particular area or what that looks like. And so some of that we have great visibility, over and do try to break that down. Some pieces we know because you all tell us and our partners. So would love to. I think I actually have a meeting set up with Washtenaw as well, I think, in the short term. So we will certainly look into that piece and make sure, again, if people are struggling to get connected with the resources they need, we can take a look at that. Yeah.
Yes, we do have the Michigan Association of Local Public Health coming up too. So Mr. Hess can share us information with us. I wanted to just drill down a little bit on the ex parte part of the process. So I'm just wondering, did the number of ex parte that you've been able to finalize meet with what the department's expectations were? And if not, are there other resources that you have in mind that we can use, or what can we do to increase the number of ex parte? Because obviously that is the simplest way to ensure we're keeping as many people in the system as possible.
Yeah, so what really helped us get our ex parte rate up was some of those federal flexibilities that came like a little bit later. So when we talk about the process and Michigan starting a little bit later, it did create the benefit of us being able to really, that's really great that you can like kind of use other programs and you can check their food assistance and their TANF and all this stuff. That's really fantastic, but that creates, like, there's a lot of system changes and things that need to happen in order to make that work, right? So we were able to use those flexibilities and get that rate up significantly. And so we were really happy with, we've more than doubled it since where we thought we were starting. And so, it's something that I will say some of those flexibilities are limited to the public health emergency. And so we have been talking with CMS and some of the congressional delegation as well of, hey, some of these pieces are really working and are great policies. And we don't just do Medicaid redetermination right now. We're going to be doing it every year. And maybe some of them aren't as important, right? And that's something that, you always learn a lot when you go through a process. So that's actually one piece that I would like to see continue, and we're kind of working with the federal government on that.
Okay, well, fantastic. Thank you so much for being patient with our questions, and we appreciate all of your incredible work, and we're here to be a partner. So I'm happy to hear from you if there are needs you anticipate for the future, because really, one of my top goals has always been accessibility for people, and we want to keep it going in the state. So thank you.
Wonderful. Thank you so much for having us.
Next, we're going to call up representatives on behalf of the Michigan Association of Health Plans. We have Bethany Swartz and Joyce Russell from Priority Health. You can come on up and join us, and we just ask that you push the mic button. That's how we can hear you.
Thank you to Chair Morse and members of the House Appropriations, Health and Human Services Subcommittee for inviting Priority Health to testify in front of you today and share our experience surrounding the Medicaid redetermination process. My name is Joyce Chan Russell, and I'm the Senior Vice President of Government Markets for Priority Health. Priority Health has made the redetermination process a top priority to ensure our members maintain access to care. And our intent today is to highlight how our team has improved our processes with the additional flexibilities and adjustments over the past few months. I plan to offer an overview of where we started with the redetermination process and then hand the mic over to Bethany Swartz, Director of Medicaid, to dive a little deeper into Priority Health's engagement with enrollees in the state of Michigan. I also want to caveat that while I will share our plan's experience and specific perspective, the Governor's Office, DIFS, MDHHS leadership, including Director Hertel and Medicaid Director Megan Groen, and the Michigan Association of Health Plans have all been amazing partners to ensure that the redetermination efforts have been nimble, innovative, thorough, and equitable to ensure as many Michiganders as possible do not lose their health insurance coverage. So I'll start with where we started. And when the redetermination process began with the end of the public health emergency in June, Priority Health was seeing a passive renewal rate of around 12 to 15%. Naturally, we were concerned about this rate of renewal, given that other states that had begun the redetermination process before Michigan were reporting passive renewal rates of around 40%. We found that the largest hurdle facing enrollees was due to members not returning their packets or having incorrect or missing information. In fact, to date, this makes up 84% of the members losing coverage. We also experienced challenges early on with getting member-level data ingested in a timely and actionable manner. Formats were changing, files had errors, and of course, this was not at all a surprise, as plans like ours, as well as the state itself, were learning as we had never taken on a redetermination process of this magnitude before. As the process developed, we were surprised and incredibly grateful with how quickly MDHHS was able to pivot and make improvements and add consistencies to the data files. It took a few months, but we were able to set up our internal systems to automate the data files from MDHHS, which improved our member-level outreach to educate beneficiaries. These early delays caused a few hiccups in our June and July beneficiary renewals. Lastly, our challenges were further exacerbated by the fact that we could not assist members in completing their packets or renewal forms online. We could only advise them to look out for their packet, direct them to the MyBridges website, or provide them with the state-provided beneficiary helpline. Now I'll turn it over to Bethany, as she has been instrumental in developing Priority Health's approach to addressing these concerns, executing our programming, and working alongside the state of Michigan to better improve the process.
Thanks, Joyce. Can you guys hear me okay? Okay, great, thanks, Joyce. So as everybody, as Joyce mentioned, my name is Bethany Swartz. I'm the Director of Medicaid for Priority Health. Joyce, you did a great job talking about where we've started. I'm gonna fast forward to today and talk a little bit about what we at Priority Health have been doing, and then I'm gonna end with a couple of suggestions for where I think we can take this for the future. So since the beginning, we've been working really closely alongside MDHHS. They've been an incredible partner with us, as well as the other health plans across the state, both in planning for and then the post-implementation when this thing kicked off in June. As a result of some early partnerships with the state, we were able to implement a multifaceted approach to help Michigan beneficiaries maintain coverage. So beginning with general awareness, Priority Health sent out communication to all 265,000 of our Medicaid members. This was via mail, phone, text, and when possible, even face-to-face interactions with our members. At that point, all we were really able to do was let people know, like, warning, warning, this is coming. We didn't have any real actionable steps for them quite yet, but the main part of that communication was update your address, go into MyBridges, let the state know, let your health plan know that you need to change your contact information or you risk missing some pretty critical information over the next year. So that was a little bit more of a widespread approach. Once the redeterminations kicked off, MDHHS started providing us with monthly lists of our members to tell us where they were at in the journey. And that was extremely helpful because that allowed us to do more of a targeted approach. Instead of just sending mass communication to 265,000 members at once, we could look at each monthly cohort and say, okay, what's happening to these members and what do they need from us for support? So this could be things from, and we're doing this today, a phone call from our concierge team. A member who's engaged with our care manager is going to hear from their care manager, a trusted nurse or social worker, about this process. They might get a home visit from their community health worker to assist them. So things that are a little bit more of a personalized, hand-holding touch that we were able to do. In some cases, members get all of the above and text messages and mailers, you name it, but we try to give folks what they need at the moment that they need it. Once Michigan applied for the waiver, and Megan mentioned it earlier, specifically the portion that allowed health plans to help members reapply, that made this process a lot more seamless on our end. So we went from just telling people what to do to actually being able to sit next to them and help them do it. And like Megan mentioned, we cannot sign for them, and that's fine. Just being able to sit with them and walk them through what can be a very complex form has been extremely beneficial. We can also go online and help them fill out the online portion as well. So a key decision that we made when MDHHS made us aware of this waiver approval, they gave us the opportunity as a health plan to say, hey, what do you want to do with this waiver? How do you want to operationalize this? So at Priority Health, we decided to stand up our own call center with 7 dedicated full-time employees that were already existing employees at Priority Health. We specifically trained them in how to complete this packet, which is challenging at times, right? It's not the easiest packet in the world. We also trained them how to go onto My Bridges and complete the form. And we also trained our care managers, our medical care coordinators, community health workers, any member-facing employee at Priority Health received training so that essentially there was no wrong door for members. If a member came up to a Priority Health employee and asked for help, they could receive that help. And then if it was maybe a little bit too complex and required more time, then our internal employees could transfer it over to this special toll-free number, this call center, where folks were a little bit more specialty trained, and that's all they do. So they're 100% dedicated to helping members reapply. Since we launched that, we've been getting anywhere from 40 to 90 calls a day on that hotline, which honestly surprised me. I did not think our members were going to take us up on that so quickly, but it's been a great resource for us, so we're happy to keep that going. Oh, let's see, what else? So we've also, and Megan mentioned this as well, been involved in the community, right? Just trying to spread the word, again, at more of a general outreach level. We do go and try to meet people where they're at and offer to help them with their packet. People don't usually carry it around in their back pocket, so that's not always extremely helpful, but going to these different community events has been great for general awareness and just letting folks know that we're here, that we're partnering with our community, we're partnering with the state. We were at the Salvation Army event that was co-sponsored by MDHHS that Megan spoke to, as long as some of our other health plan that are across the state of Michigan. And I think it's really great as a state that we're all coming together to work on this as a state problem instead of an individualized problem. The last thing I'll mention, and then I'll move on to some statistics about how we're doing. We also formed a steering committee between Priority Health and Corewell Health, because as an integrated health system, we wanted to use the full reach of our providers and our plan. So by just ensuring that we're working together, we're not duplicating efforts, and we're making sure that our provider partners know what they can do to help their patients at the point of care. Because sadly, a lot of people aren't finding out that they're losing coverage until they show up for an appointment, show up in the ED, try to fill a prescription. So it's really important to us to do our part to educate the medical community as well, since we are an integrated health system. Okay, so all of this effort, what is it doing for us? We are extremely encouraged by our initial results these first 3 months. We're seeing around a 69% re-enrollment rate, which includes those that are passively renewed, as well as those members that have to actually complete a form and then they get requalified. So that leaves about 31% of our members who have lost coverage. And of those, because again, of what Megan had stated before, that retro re-enrollment period for 90 days, we've actually been able to capture back 16% of the 31% that we lost originally because they didn't act in time. And we think that's fantastic. Now, not all of those members are coming back to Medicaid, which I think, again, is a great thing. Some of those members are picking an ACA plan. They're on a group commercial plan. They qualify for Medicare, and that's wonderful. We want to help our members get to the plan that best meets their needs where they're at in their life. And we can track that so long as it's a Priority Health plan. We then can see where those members are going. Joyce mentioned that at the beginning, our passive renewal rates were 12 to 15%. They're now over 50. I think this last month was 55% for Priority Health. So again, that's nothing that we did. That's the efforts that the state's taking that you heard Megan speak to earlier. But it's really helpful because it does allow us to target our resources towards folks who truly need our help. So despite all of those successes, we do still have about 16% of our members who are losing coverage month over month. So of course, there's always room for process improvement, right? I have 3 specific suggestions that I'll label today that our plan thinks could be helpful as we're out there, boots on the ground, talking to members and what we think would be the best path forward for the next year and beyond. So half the battle is meeting people where they're at, right? The availability of these blank renewal forms, we don't have them at our disposal. And I don't want to say that I know why. I'm not sure if they have barcodes on them and if they, they go directly to an exact member. I can't really speak to that. But what I do know is that our staff who are out there helping members, they feel it would be extremely beneficial if we could have the renewal packet, a blank copy, because when we're going to these events or when we're calling members, like I said, people don't have this form that they just carry around with them, right? So if we had it with us and we could say, oh no, sit down and let's do it together right now, I have a copy for you, that would be really helpful, and I think it would make some of these community events even more fruitful, so to speak, to help more people. Another idea that we have is around data sharing. So I mentioned that we still have a good chunk of folks who are falling off of Medicaid. For Priority Health, that's about 4,000 members a month that are just falling off Medicaid, and I don't know where they're going. Okay, some of them, like I said, if they join a Priority Health commercial plan, I can see them move, and I know they still have coverage. But to the folks who aren't submitting a packet back, we have no data about what's happening to them, and that worries me. Is that member just without coverage? Did that member go to maybe a Blues commercial plan, right? And that would be great if they did, but I don't know that. So we're using all of our resources to call these 4,000 members a month, right, to make sure that they're not without coverage, when in reality, some of them, maybe they already have another coverage and therefore they didn't return a packet because they knew they didn't need it or wouldn't qualify. Like, no one's going to fill out that form if they don't actually need Medicaid, right? So if there was some way at the state level for whether it's all the health plans to come together, I don't know what data the state might get, but to understand what is happening to these members who aren't acting, that would be extremely helpful, and we can then continue to narrow down who we're reaching out to so that we're using our resources to the best of our abilities. And then lastly, I will say that we do think it's time to start planning ahead. So just as we've already talked about today, this is a process that has gone on well before COVID hit us, right? And it's going to continue well after this first year. So we would love to start talking now about what can continue on after May of 2024. We have seen amazing support, like I said, from CMS and MDHHS on different waivers. The state dashboard is wonderful. The member level file transfers that the state gives us every month. These have been so helpful for us to help our members. And if those just automatically stop in May, then I do worry about what that's going to look like for members moving forward. Right now, we don't know. Nobody has said it will stop. I think we just don't know if some of these waivers are going to continue. But I do think it's time for us to start figuring that out, because as a plan and as the state, we can start automating some of these processes. Just to give you a little example, I mean, we've already spent over $800,000 to date on just some of the things I've mentioned above, right? We're expecting to spend another $500,000 to $600,000 through June just to close out this first year. If we can automate some of what we're doing, and if we knew it was going to be permanent, I think that would help us all just use resources a little bit better. I think that's all I had for today, but in closing, I just want to say thank you for letting us be here today. It's been great to talk about what our plan's doing, as well as the partnership with the state. We're extremely grateful for all of your support and for the partnership that we have with MDHHS. So happy to take any questions, but again, thanks.
Well, thank you so much for what I found to be very encouraging testimony. It's great to hear how everyone's working together, including the federal government, to ensure that, again, we are keeping as many people on their health care plans as we can. So I didn't receive any questions. Oh. Go ahead, Rep. Meerman.
Thank you, Madam Chair. Do you see the same progression back to pre-pandemic, stretching all the way out to 2027 as MDHHS did? What are your projections on when we, or aren't we gonna get to pre-pandemic, it's still gonna be elevated from that?
No, we're expecting a slight elevation. Like our actuarial team has been doing projections and trying to mirror them across national models. It's so difficult because even the best national models in the world are basing it on something that's never happened before, right? We expect a slight elevation from where we start. But right now, like we're already seeing, we're losing the same amount of folks that we did pre-pandemic. So I think that they call it the Medicaid churn, right? Folks fall on and off plan all the time, and that is just the nature of Medicaid. And so to me, it's a little encouraging to see that we're already seeing the same patterns start back up again. I expect that to continue on forever, though.
So where are we compared to pre-pandemic levels now? What % drop? You said probably not all the way down.
Yeah, I don't know that for the whole state. Like, I don't know how much we've dropped as a state. I know
Priority?
as a plan.
Yeah.
Yeah, so we've already dropped 30,000 members, and we started at 265,000.
Okay,
Just in the few months that we've been going. So.
thank you.
Yep, you're welcome.
Well, again, thank you so much for joining us today. Finally, we're going to welcome up Norm Hess, Executive Director of the Michigan Association of Local Public Health. Thank you, Norm, for joining us today.
Good morning. Thank you, Chair Morse and members of the subcommittee for allowing me time this morning. I am Norm Hess. I'm the Executive Director of the Michigan Association for Local Public Health, and we are the statewide association of all the 45 city, county, and district local public health departments in Michigan. Let me see if I can move this a little bit. No, I can't. Leave it. So I would like to give you a little bit of a perspective from local public health about the need for this redetermination process to be successful. And so I ask you to bear with me for the next two slides, just as context for what's happening here. Social determinants of health are an individual's personal circumstance that impact their health and well-being. They include political, socioeconomic, and cultural factors alongside how easily someone can access health care, education, a safe place to live, et cetera. So in public health, we talk a lot about the social determinants of health and how our work has, over the last 100 years, sort of shifted away from infectious diseases, not shifted away, but a focus is now more on chronic disease management and prevention, as well as the social factors that influence someone's health, because most of what happens that impacts your health happens outside of a doctor's office or a hospital. But one core function of local public health is to make sure that people have access to health care and to make those linkages available. One document that kind of drives our work on a national level are the Healthy People 2030 objectives. There are now 359 objectives that are designed to measure impact of various programs on the public health of Americans. And so they could be reducing the percent of preterm births, or reducing the number of mothers who die during childbirth, screening for cancers of various types, and reducing preventable deaths from injuries and accidents. And there are a number of objectives that have to do with healthcare coverage. This is just an example. Reduce the proportion of people who can't get medical care when they need it. So there are you know, healthcare coverage is not the only factor that influences whether a person can get medical care when they need it. They may have healthcare coverage, but there may be no providers in their area. They may have a car, but it has 2 flat tires and they can't afford to fix it, so they can't get to their appointments. But the healthcare coverage is absolutely critical to the public health of Americans and people in our state. And if people lose their healthcare coverage, this cascade of events can happen where they delay care, they have more complications, they end up in the emergency room and perhaps hospitalized. There is an increased risk of disability, and then costs go up. So Medicaid is very important to the public health of Michigan. And as you've heard, there are 3 million people in Michigan who rely on Medicaid for their health care coverage. So Medicaid policies and practices are very important. As those go, so goes, in some sense, the public health of Michigan. Now, there are biases against people who rely on Medicaid. I'm sure not in this state, but in other states, people seem to think that it's a good goal to get people off of Medicaid and save the state some money. I will tell you that doesn't really work that well. There's also a perception of widespread abuse of Medicaid benefits in the system. And, you know, you create any system, there's going to be certain people who find ways to use it in ways that it wasn't intended. But I would submit to you that the majority of people who rely on Medicaid in this state are hardworking individuals who are trying to make ends meet and who are facing complicated situations in their lives. So allowing people to be disenrolled only to be later enrolled is obviously in no one's best interest. It's costly, it's inefficient, and potentially detrimental. And people who have health care coverage are actually more able to work because they're able to address their health issues when they're small health issues. They don't have to take a lot of time off to recuperate and things like that. So anyway, I'm glad to hear that your goal is to keep as many people on Medicaid as possible. So just a few more thoughts on Medicaid. I don't think I have to remind you that this is notoriously difficult. It's a state and a federal program. So there are state requirements, there are federal requirements. It's just complex. There's just no way around that. As was pointed out earlier, redeterminations are not anything new. It's just that COVID has exacerbated any of the previous issues with this process, and Michigan faces a monumental task. I am pleased that MDHHS is being creative in problem solving. I think that many of those waivers are helpful, and as Bethany said, I'm hopeful that some of those may be able to be extended beyond this time period to make the process easier in the long term, because it's not a process, it's always going to be with us. But recent experience shows that of the redetermined cases, 6.4% are closed due to ineligibility, but 30.4% are closed for procedural reasons. So that, as Megan said, people are not returning their packets, and it's just, we're losing people through that system. So a couple of current challenges. These are just things that I am hearing from partners in the field. I have heard very good feedback about the MDHHS letters that they created. That you need to do this, you need to do this, you need to do this. Very easily understood. However, once people actually delve into the applications and the MyBridges, they run into things that does not allow them to move forward. They don't understand it. And then when they have to reach out for help, even though the wait time, telephone wait times, which absolutely we would have expected to be a problem in the beginning, I hear that they're getting better. But if the person is calling that while they're on their break from work, they have to abandon the call for any reason or leave a message. Of course, it's difficult then. It adds another layer of complexity to try to get in touch with them. People on Medicaid are, they're just very difficult to connect with. And I hear that the auto-generated letters that come out of My Bridges are sometimes difficult to interpret, especially if there is a denial. People are not 100% sure if they're denied because they did something wrong or if they denied because they really are ineligible now. So that's an issue that continues. And then passwords and account recovery is still so I'm very, I applaud MDHHS for adding the capacity that they have. Excuse me. I will say that, this is a complex process that involves advanced technology and humans. I would say if there's anything that I would suggest, it is that there still is a need for more humans to help people walk through this process. You can say, if they just return their packet, everything would be fine, but the reality is there are many reasons why that doesn't happen. And I would say, especially at the community level, in community partner organizations, who come into contact with people who need to be redetermined, but that's not the reason they're there. If there are more people who can guide them through the process, I think that would be helpful. So that is what I have to share with you this morning, and I would be happy to take any questions.
Well, thank you so much, Norm, for being here and giving very concise testimony, quick testimony this morning on what you're seeing at the county health level. Does anyone have any questions? Rep. Steele?
Sorry, this might not, you just have brought up a question, but you might not be able to answer it. So when you say that there are long wait times, do you have any idea how long a wait time might be, like on a phone? Because I'm not aging population, but I am moving towards that, and human contact to help me through is very helpful. I'm not all computerized. So I would like to know how long that they have to wait. And are all the employees that, in this you might not be able to answer either, working from the state, or are they working from home? And I'm just wondering if we're losing some of the capacity because not everybody is working full-time at the state to be able to be more efficient. So I guess those are questions I don't know if you'll be able to answer.
So you're right, I can't. I do not know exactly what the current wait times are, but I know MDHHS is tracking it. I am hearing that they are getting better, and as they have ramped up people. But I will say that, especially I think with this population, a wait time, if you're calling for something, I don't know, if you're calling to cash in your lottery ticket, a longer wait time is acceptable, but for this particular process, even a short wait time is going to be frustrating. And so you can only bring them down so much, but if people don't get a human, that is when I think we are losing another chunk of people if they're not getting, especially if they don't get a human on their first call and they have to leave a message and then wait for a call back. That's just, that's nobody's fault, but it's just a process thing. And I don't know what percent of people are working from home or through the state. I'm not sure how that would affect the time, but
34% seems like a lot that people aren't being able to get the Medicaid based on procedures. So the procedural process of re-enrollment. So
right.
Thank you.
Rep. Hood?
Thank you. This reminds me a lot of our work to bring earned income tax credit dollars from the federal government into the state, in that it really took a very well-designed and collaborative effort between organizations of trust and communities and this state institutions to make sure that people had the assistance that they needed to fill out the forms, and that those community as institutions of trust had purview to be able to access, in this case, the IRS, or, here, MDHHS, to get that immediate response to, receive forms, process them, and get any glitches fixed in that rare moment you have a person in need in front of you, right? And there's just a certain part of the population, especially in the Medicaid population, that is going to struggle with forms, struggle with online systems, in addition to the struggle we all have with bureaucracy and its inefficiencies. So can you talk a little bit more about how community organizations are partnered, and are there efforts, maybe it is EITC or census efforts or other efforts that we could use, as models to create that connectivity we need between on-the-ground folks in community who are able to help with these technical pieces, individuals, and the department? Do you see any opportunities there?
I do, and please don't hear what I'm not saying, that I'm not saying that MDHHS is not doing this already. I'm just saying that if there is an opportunity for continued improvement, I would say that the partnerships with organizations in local communities who automatically come in contact with people on Medicaid, that I think there might be some opportunity for increased collaboration, increased connection, things like that. So Representative Braybeck had mentioned the Washtenaw Health Plan. I think that we still have 3 county health plans in this state. I think that those are folks who are very well positioned to offer suggestions and alternatives. There are many organizations that employ navigators, community health workers, local public health departments do. There are other local coalitions that do. And so I do think that there are opportunities would be happy to, assist with connections in that way. I'm not sure, did I get your question? Or?
So to summarize, if we were to make any additional investments in helping to solve this problem, it would be, what I'm hearing from you is it would be wise to engage those organizations that have community health navigation assets that could be deployed towards this purpose.
I would say that's true, exactly, yes.
In addition to meeting any additional needs DHHS anticipates. Thank you.
Exactly, thank you.
Well, thank you, Director Hess, so much for joining us today in this important information. I want to again thank all of the individuals who testified today. It was really our goal to ensure that we're raising public awareness that this is a process that's continuing to happen, and just hearing, about how the state's doing and what we can do to improve the process, and again, make sure we're keeping as many people with coverage as possible. And with that, seeing no further business, Rep. Hood moves to excuse absent members. Hearing no objection, absent members are excused. And now, seeing no further business, this meeting is adjourned.